Welcome to NP Talk, developed by the Faith and Fortitude creators. Here, we will discuss topics particularly to build your knowledge and prepare you for your nurse practitioner exam.
Yes, whether it's through the AANP or ANCC exam, listen in on our podcasters as they dive into various topics from pediatric health, women's health, down to assessments, diagnosis, and evaluation domains.
Please like, subscribe, and comment on our channel. Tell us what other topics you would like us to cover.
Happy learning!
Welcome to the deep dive. Today, we are wading into a truly vast and, well, pretty complex pharmacological sea, the world of antibiotics.
It's a huge topic.
Absolutely. We've pulled together a comprehensive stack of sources, and our mission, really, is to give you a shortcut, a way to understand how these critical drugs are classified.
What the risks are.
Exactly. The universal risks, what makes them work, and maybe more importantly now, what makes them stop working.
Yeah, and you hit on the main challenge right away. Choosing the right antibacterial agent. It's tough. There's just a remarkable array of drugs out there.
It's overwhelming.
It can be. But for you, the learner, the key is understanding how they're grouped into classes. And these classes are based on their biochemical structure.
Okay, so structure dictates function, basically.
Pretty much. Once you know the class, you instantly get a handle on shared characteristics, like the common mechanism of action, the typical side effects, how the body clears the drug. It's sort of a shortcut to confidence.
That structural grouping sounds like the foundation, then. Our overview today, it draws from sources looking at 8 major classes. We'll talk about the big ones: penicillins, quinolones.
The classics.
Right. Plus, we have to take a necessary deep look at some newer agents and, let's be frank, the biggest battle facing modern medicine, antibiotic resistance.
Maybe we should start with the ground rules, the things that kind of tie all antibiotics together, regardless of class.
Good idea. So, universal factors. Our sources point to 2.
That's right. 2 things shared by all antibiotic agents. Doesn't matter which class.
Okay, 2 risks you absolutely have to think about every single time one of these is used. What are they?
First one, the risk of allergy. Simple as that. All antibiotics can trigger allergic responses.
And that can be minor.
Yeah, like mild rashes, or it can be truly life-threatening. Think anaphylaxis or Stevens-Johnson syndrome. Serious stuff.
Okay, allergy is number 1. What's the second universal factor?
That's the disruption of our normal body flora. You could call it the gut risk, maybe.
Because the antibiotic isn't selective, is it? It's kind of a blunt instrument. Kills the bad guys, but takes out some of the good bacteria, too.
Precisely. And that creates this biological vacuum, which opens the door for opportunistic pathogens.
Like yeast infections.
Often, yeah. You see overgrowth of Candida species. Or, more seriously, pathogenic bacteria like Clostridioides difficile. C. diff.
C. diff is nasty.
It really is. And what's particularly worrying for patients, and clinicians too, is that C. difficile colitis. It might not pop up during treatment. It could develop days, even weeks, after you've stopped the main antibiotic.
Wow, so the threat lingers. That delayed risk is really critical context.
Definitely.
Now, thinking about allergies, let's tackle the big one. Penicillin. We've always heard about penicillin allergy, right? Like it's this huge red flag. Has that view changed?
Oh, significantly,
Yeah.
yes. Traditionally, the thinking was maybe up to 10% of patients had a reaction.
Which is a lot.
It is.
Yeah.
But recent, much better studies show the true rate of that severe IgE-mediated allergy. It's way lower, sometimes down around 0.7%.
0.7%. That's a massive difference from 10%.
Huge. And here's something maybe even more important. About 90% of people who were once labeled with a penicillin allergy, they actually lose that reactivity over about 10 years.
90% lose it over a decade. So does that mean a huge number of people walking around with a penicillin allergy label on their chart? Maybe they could take it safely now, or maybe never even had a true allergy to begin with.
That's exactly the implication, and it has enormous clinical consequences for choosing drugs, especially when you think about cross-reactivity.
Right, with other beta-lactams like the cephalosporins, the old thinking was they were all risky if you reacted to penicillin.
Yeah, that was the common misperception, that the core beta-lactam ring itself caused the cross-reaction. But we know now it's mostly about the side chains, the similarity in those side structures.
That's chains.
Exactly. And because of that, the cross-reaction rate with, say, third-generation cephalosporins, it gets close to 0. Their side chains are just really different from the common penicillins.
That's such a practical distinction. It really opens up safer treatment options for people, doesn't it? Stops them being pushed towards maybe broader spectrum drugs with potentially worse side effects.
Absolutely. But, all this progress and understanding, it's constantly under threat from that second big topic we mentioned, antibiotic resistance.
Yeah, the relentless problem. How do we even start to stay ahead of these microbes?
Well, that's the billion-dollar question, isn't it? Repeated exposure, it just inevitably selects for resistant strains.
Yeah.
And the scale is, well, it's frightening.
Mm.
The CDC figures, you mentioned them earlier,
Millions of infections, right?
about 2.8 million infections and roughly 35,000 deaths every year,
Yeah.
just in the U.S. And that's specifically due to resistant bacteria.
So if we look at the bacteria themselves,
Yeah.
what's their strategy? How do they actually become resistant? What are the mechanisms?
They're incredibly adaptable. Our sources highlight several key tactics they use, often at the same time. First up is decreased permeability.
So they just try to keep the drug out.
Basically, yeah, they change their cellular gates, their entry points, limiting how much drug can actually get inside the cell to do its job. We see this with beta-lactams, quinolones, vancomycin too.
Okay, so block the entrance. But if the drug does get in, what's plan B? Do they just pump it back out?
That's their escape hatch.
Yeah.
Exactly. Increased efflux. They use these specialized pumps in their membranes to actively eject the antibiotic right back out.
Like tiny bouncers throwing the drug out of the club.
Yeah, pretty much. Tetracyclines and quinolones are often kicked out this way.
Okay, so keep it out or pump it out. What's the third tactic? Something about destroying the drug.
Correct. Enzymatic deactivation. This is maybe the most famous one. Bacteria produce these sophisticated enzymes.
Yeah.
Think beta-lactamus.
Ah, the ones that chew up penicillins.
And cephalosporins, too. These enzymes physically destroy the antibiotic molecule itself, so it can't bind to its target.
Clever. And the fourth way?
Target site alteration. The bacteria basically mutate the spot where the drug is supposed to bind. They change the lock, so the antibiotic key doesn't fit anymore.
So even if the drug gets in, it can't do its job.
Precisely. This is why altered DNA gyrase stops quinolones working, for example, or why changing the ribosome through methylation can block macrolides.
What makes this whole resistance threat so incredibly dangerous, though, isn't just these individual mutations happening slowly, right? It's the speed, how fast it spreads.
That's the really scary part, the microbial superspreader element. Resistance isn't just a slow burn within one bacterial line. It jumps.
Ow.
It's often transferred incredibly quickly from one bacterium to another, sometimes even across related species. They use these small, mobile bits of DNA called plasmids or transposons.
Like little genetic USB sticks.
Exactly like that, carrying the instructions for resistance, ready to be copied and shared rapidly throughout the bacterial population.
Okay, that's sobering. So how do we fight back? What's this antimicrobial stewardship idea about?
It's about using the antibiotics we have more wisely. Strategies can include combining drugs like sulfonamides paired with trimethoprim. They work better together. Right. Or using inhibitor drugs, like adding clavulanic acid to amoxicillin. The clavulanic acid basically sacrifices itself to the beta-lactamase enzymes.
Letting the amoxicillin do its job.
Exactly. And the good news is, these stewardship efforts seem to be working, at least in hospitals. The CDC tracks this stuff, and their progress reports show real decreases in hospital-onset infections.
Like what kind of numbers?
Pretty substantial drops. A 36% decrease in C. Difficile infections that started in the hospital. MRSA bloodstream infections down 31.5%. And hospital-onset Pseudomonas aeruginosa infections down a massive 41%.
Wow, okay. Those numbers offer some genuine hope that we can manage this threat if we're smart about it.
It shows stewardship matters.
Definitely. Let's shift gears now and dive into some of the classic antibiotic classes, starting with the absolute original, penicillins, discovered by Fleming back in 1928.
Yeah, though really only available for general use from the 1940s onwards.
And their basic mechanism, how do they work?
They're bactericidal. They kill bacteria directly. They do it by messing up the construction of the bacterial cell wall.
How?
They bind to specific bacterial proteins called penicillin-binding proteins, PBPs. This binding stops the cross-linking process needed for a strong wall. So the wall gets weak, the cell basically bursts, lysis and death.
Got it. And the penicillins themselves, they aren't just one drug, they're grouped, right?
Right. Several key categories based on what they cover. First, you have the natural penicillins, like penicillin G or V.
What do they hit?
Mainly gram-positive organisms and anaerobes. But, crucially, most Staphylococcus aureus isolates out there now, they're resistant so their use is more limited today,
Okay, then came the aminopenicillins.
like ampicillin and amoxicillin. These offered better coverage against some gram-negative bacilli, a little broader spectrum.
And amoxicillin is the one we often see prescribed orally.
Yes, and for good reason. It has much better oral absorption than ampicillin, and a key practical point. Taking it with food doesn't affect how well it's absorbed, makes it easier for patients.
Right, and then because bacteria started making that enzyme, penicillinase, we had to counter that, didn't we?
We did. That led to the development of the penicillinase-resistant penicillins. Think nafcillin, oxacillin, dicloxacillin, designed specifically to withstand those penicillinase enzymes produced by SORAS.
That constant back and forth. Which leads us naturally to the next big class, the cephalosporins.
Also beta-lactams. They use that exact same mechanism, inhibiting cell wall synthesis by binding to PBPs.
But we group them differently, don't we? Into generations.
We do. It's mainly based on when they were developed and their general spectrum of activity, what they cover.
Okay, so if we needed a quick rule of thumb for the generations, is it fair to say that as you go up in generation number, the activity against gram-negative bacteria generally increases?
That's a perfect rule of thumb. Generally, yes. So first-generation cephalosporins like cefazolin or cephalexin, they're best against aerobic gram-positive cocci. Great for things like basic skin infections.
And as you go higher?
The gram-negative coverage tends to expand, maybe at the expense of some gram-positive punch, until you get to the fifth generation. And there you find some really interesting specialized agents, like heptarolanfosamil.
Ah, ceftaroline, that's the one that targets MRSA, right? That's its unique selling point.
That's the one. It's unique because it has a really high affinity for a specific PBP called PBP2A.
And PDP2A is the protein that makes MRSA resistant to other beta-lactams.
Exactly. That high affinity makes ceftaroline highly active against MRSA and also against multi-drug-resistant Streptococcus pneumonia. A real problem-solver drug.
Okay, so we've covered the beta-lactams. Let's move away from cell walls and look at a couple of other classes. Maybe start with the quinolones. They work totally differently, but come with some pretty significant updated safety warnings.
Yes, the quinolones, or more accurately, the fluoroquinolones. Their mechanism is quite distinct. They inhibit essential bacterial enzymes, DNA gyrase and topoisomerase IV.
What do those enzymes normally do?
They're crucial for DNA, replication, transcription, repair, basically managing the bacterial DNA. By inhibiting them, quinolones cause permanent breaks of the bacterial chromosome. It's lethal. Leads to rapid cell death.
They sound potent, but you mentioned warnings.
Very potent. But yes, the warnings are serious. Our sources really stressed the 2018 FDA update. It significantly strengthened the warnings about systemic risks.
What kind of risks are we talking about?
Several major ones. Risk of disabling and potentially permanent peripheral neuropathy, nerve damage. Also, serious mental health side effects.
Like what?
Things like disorientation, agitation, nervousness, memory impairment, even delirium. And on top of that, serious disturbances in blood sugar, including hypoglycemia, low blood sugar, that can be severe enough to cause coma.
Wow, that's a heavy list of potential harms. It really underscores why these drugs need very careful patient selection, doesn't it?
Absolutely. Their use has become much more restricted because of these potential side effects.
Okay, let's turn to another class with its own set of considerations. The tetracyclines.
Right. Tetracyclines work differently again. They are bacteriostatic, meaning they generally inhibit bacterial growth rather than killing the cells outright, at least at typical concentrations.
And how do they do that?
They inhibit protein synthesis. Specifically, they bind to the 30S ribosomal subunit and block the attachment of aminoacyl tRNA, stops the protein chain from growing.
What are they used for nowadays? I feel like you don't see them prescribed for everyday infections as much.
You're right. Their role in really common infections has shrunk quite a bit, mainly due to high levels of resistance that have built up over the years.
But they're still important for certain things.
Oh, absolutely critical for some specific types of infections. They remain essential for atypical bacteria, like chlamydia, mycoplasma, rickettsia, and they're very important for treating zoonoses, infections spread from animals, like Lyme disease or Rocky Mountain spotted fever.
Now, wasn't there always a big warning about using tetracyclines in young children? Something about teeth.
Yes, that was the traditional teaching, and it was a real concern. They were strictly contraindicated, generally, in kids under 8 years old.
Why was that?
Because if given during the time teeth are developing, they can bind to calcium and get incorporated into the enamel, causing permanent staining or discoloration, and sometimes enamel hypoplasia.
But hasn't that advice changed recently? especially for certain situations.
It has, and it's a really important update. The data now shows that for treating serious illnesses like Rocky Mountain spotted fever, doxycycline, which is a tetracycline, is actually the recommended first-line therapy for children of all ages, even those under 8.
Really? So the tooth staining isn't a concern anymore?
The consensus now, based on studies looking specifically at short courses used for these serious infections, is that the risk of clinically significant dental staining is negligible or non-existent. The benefit of using the most effective drug for a potentially fatal disease like RMSF far outweighs that theoretical risk.
That's fascinating. A great example of how medical guidance evolves as we get better data.
It really is. Evidence overriding long-held caution.
Okay, let's briefly touch on one more powerhouse antibiotic, especially important for those resistant gram-positive infections, vancomycin.
Vanco. Yes, it's a glycopeptide antibiotic. It's our key intravenous agent for serious MRSA infections, particularly bloodstream infections, pneumonia, bone infections, things where beta-lactams won't work.
It sounds like a lifesaver, but I also hear it's tricky to use.
It is powerful, but yes, it requires careful management. It has what we call a narrow therapeutic index.
Meaning the dose that works is quite close to the dose that causes harm?
Exactly. Too low, and it won't kill the bacteria effectively and might promote resistance. Too high, and you run into toxicity, particularly nephrotoxicity, kidney damage. That's why therapeutic drug monitoring, checking levels in the blood, is mandatory.
Makes sense. And isn't there a famous side effect associated with how it's given?
Yes. The infamous red man syndrome, or sometimes red neck syndrome.
What is that? Is it an allergy?
Not a true allergy, usually. It's a histamine-mediated reaction caused by infusing the drug too quickly. Causes flushing, redness, itching, mainly on the upper body, neck, and face.
So it's preventable.
Entirely preventable, yes. The key is just ensuring the IV infusion rate is slow enough. The standard recommendation is no faster than 500 milligrams per hour. Go slow, and you generally avoid the reaction.
Good to know. Okay, we're nearing the end. Let's look briefly to the horizon. What's coming down the pipeline? Are there investigational antibiotics being designed specifically to get around all these resistance mechanisms we've talked about?
There's a lot of research, definitely. 2 agents mentioned in our sources stand out because they have genuinely novel mechanisms. First is tixobactam.
Tixobactam, what's special about it?
What's really fascinating is how it works. It doesn't target proteins like most antibiotics. It binds to essential precursors of the cell wall, specifically molecules called lipid 3 and lipid 3.
So it hits a different part of the process entirely.
Exactly. And because it targets these non-protein, highly conserved precursors, it's shown effectiveness against tough bugs like MRSA and even vancomycin-resistant Enterococcus VRE. And crucially, so far, there's no known cross-resistance with existing drug classes. It could be a genuine new class.
That sounds promising. What was the second one? Something about RNA polymerase?
Yes, pseudoerythromycin. This one is a nucleoside analog inhibitor. It works by inhibiting bacterial RNA polymerase, which is the enzyme bacteria use to transcribe DNA into RNA.
But don't we already have drugs that inhibit RNA polymerase, like rifampin?
We do. But the key thing about pseudoerythromycin is that its mechanism, how it binds and inhibits the enzyme, is distinct from rifampin's.
So it might work even if the bacteria are already resistant to rifampin.
That's the potential benefit, yes. That difference in binding site could allow it to bypass existing resistance mechanisms targeting RNA polymerase, offering a new way to shut down transcription in resistant bacteria.
Very interesting. Okay, we've covered a huge amount of ground. The classics, the universal risks, the scary ways bacteria fight back, stewardship, and a peek at the future. If you had to boil it down, what's the big picture takeaway from this deep dive for someone trying to understand antibiotics?
I think the ultimate goal in this whole field is always about finding that careful balance. We need to maximize how well the drugs work for the patient, ensure their safety, but always be thinking about limiting the selection pressure that drives resistance.
And understanding the classes helps with that.
Definitely. Understanding how these drugs are grouped by class, by mechanism, how they kill or stop the bacteria, it really enhances your confidence. Whether you're prescribing them, administering them, or just trying to make sense of complex medical news, knowing the fundamentals makes a difference.
It feels like this constant arms race, doesn't it? Between us developing new drugs and the bacteria rapidly adapting using those mobile genetic elements, the plasmids and transposons, it seems endless.
It often feels that way.
So, considering that, and thinking about the CDC's big push on the One Health approach. Recognizing that human health, animal health, and environmental health are all deeply interconnected. Here's a final thought for you, our listener. What non-pharmaceutical intervention, maybe something related to that One Health idea, do you think will prove most critical in the next decade for actually slowing down the spread of resistance? Something beyond just making new drugs. I'll leave that question with you to ponder.